My name is Elizabeth Burford, and this is for my 2018 master's project for PA school. I chose to do my master's project on autistic disorder because I'm very interested in pediatrics and specifically psychiatric issues within pediatrics. I will start off with some general features about autistic disorder, starting with a little background on the subject. In 2013, the DSM-5 was published, and it removed all former diagnoses to create a new single diagnosis of autism spectrum disorder. Now, researchers are attempting to find causal relationships that tip the scales in favor of genetics, the environment, or the interplay between the two to explain the etiology of ASD, autism spectrum disorder. The most convincing and publicized evidence points to increased maternal and paternal age. Mixed evidence has been found surrounding maternal infections, autoimmune diseases, environmental pollutants, and maternal medications such as antidepressants. The prevalence of ASD continues to increase, and this could be due to improved screening tools leading to more diagnoses of ASD or unknown factors. Current statistics show 1 in 68 children are diagnosed with ASD, and boys are 4.5 times more likely than girls to be diagnosed. Studies have shown that non-Hispanic white children are diagnosed with ASD more often than non-Hispanic Black and Hispanic children. Now, for information on clinical assessment of ASD. For signs and symptoms, by definition, ASD is diagnosed on a spectrum, and children can present with initial core delays in language and/or social development, or have typical development and later plateau or regress. Children with ASD often begin experiencing delays between 1 to 2 years of age. Now, language abnormalities that may be seen by the child are using echolalia, reversing pronouns, using their own language, or answering questions with an unrelated answer. They often prefer solo play and display apathy toward other children, leading to poor social relationships. They have difficulty with non-verbal communication behaviors, such as body language and emotional cues. Repetition is a key factor seen in the lives of children with ASD. They often display repetitive mannerisms, such as rocking or hand flapping. They often demand sameness in their routines, and deviations may elicit a tantrum. They often have a negative affinity toward physical contact. Now, ASD is diagnosed clinically using the patient's history, physical exam, the DSM-5, and other diagnostic tools. It is recommended that PCPs, primary care providers, perform routine developmental screening at well-child visits and perform autism screenings at age 18 and 24 months. If the PCP's medical evaluation is consistent with ASD, it is advised that the PCP refer the child to an ASD specialist for a comprehensive and formal evaluation. These specialists can include developmental pediatricians, pediatric neurologists, and pediatric psychologists or psychiatrists. Other testing should include genetic testing and counseling, and hearing and vision screening. The DSM-5 divides the signs and symptoms of ASD into 2 categories of having persistent deficits in social communication interaction and restricted repetitive patterns of behavior, interaction, and activities. The ADIR is a diagnostic scale used and consists of an interview lasting several hours that is conducted with the parents whose child is 4 to 5 years old. Another scale used is the ADOS, or ADOS, and it assesses the child's social and language abilities through 4 interactive modules with individual scores and an overall score. Now for treatment. If patients with ASD have comorbid conditions such as ADHD or anxiety, they can be treated pharmacologically for those conditions. It is important to monitor side effects and remember the core symptoms of ASD will still exist. Now, no official treatment guidelines for ASD exist because patients require an individualized treatment approach. The consensus is that early behavioral intervention leads to better outcomes. The main behavioral intervention used is applied behavior analysis, and it breaks down learned skills with a reward system. ASD patients should receive at least 25 hours of individualized services a week. It is important that they work with speech therapists to improve communication skills and occupational therapists to improve independent living skills and sensory and motor abnormalities. Many parents seek out complementary and alternative therapies. A popular and proven method are animal intervention studies, as they have shown a decrease in ASD symptoms. It is important to educate parents on unsubstantiated therapies. The prognosis of children with ASD is highly dependent on IQ and symptom severity at diagnosis. When it is a possibility, independence should always be the eventual goal. Since one cannot prevent ASD, parents must be educated on the common signs and symptoms to ensure early detection and treatment. One of the first signs is failure to respond by name. This often leads parents to wonder if their child is hearing impaired. These children should have a hearing test to rule out this possibility. I have included my references used in this presentation. I hope this presentation is helpful while you study for your PANCE. Thank you.